Hello, welcome to another online lecture for Nursing 234 Intermediate Medical Surgical Nursing. Today's topic will be Cancers of the GI System by Professor Nicholas Garcia. The objectives today you would find in your syllabus for the module regarding GI system. And it's to relate the care of the patient with esophageal cancer, describe etiology, manifestations, and treatment for patients with gastric cancer, describe a plan of care for a patient with the colorectal cancer. We're going to kick around etiology and pathophys, of course, and clinical manifestations. This is paramount for us as nurses because this is what we need to look for as our patients present with signs and symptoms. We have to know when we see this, what we're going to do about it, and who to alert. We'll discuss staging, diagnostic studies, risk factors, treatments, surgery, radiation, chemotherapy. And of course, you want to do all of this so you can formulate a plan of care for your patient. And the first step in doing that, of course, is labeling it with some sort of direction. And of course, we know that as nursing diagnosis. Okay, so let's talk about how cancer develops. Probably learned a little something in fundamentals about cancer and how it first develops. And it first develops from a mutation in a single cell that turns on the replication, the mitosis process all over again at a rapid, aggressive rate. So whatever carcinogens you've been exposed to or one has been exposed to that turns on this mutation causes the cells to grow from a point of origin, causes them to grow at an uncontrollable rate and invade surrounding tissues and organs, impeding their functionality. Cancer cells fail to develop into the type of normal cells from which they originate. They spread from the site of origin, spreading to surrounding tissues aggressively and rapidly. They do this by invading into the lymph system or the venous system, so it causes them to circulate systemically at times. This process, when they move from a point of origin to another, is called metastasis. So if you've ever heard the different terms of cancer, like someone told you they have some sort of blastoma or leukemia or something like that, you probably wondered how they come up with these names. And these names are derived by the type of tissue or blood cells from which the cancers originate. If they develop in the epithelial tissues, then they're called carcinomas, and these are the most common. Glandular tissues are called adenocarcinomas. Connective muscle and bone is called sarcomas. Tissues of the brain and spinal cord are called gliomas. Pigment cells, so we hear this one a lot nowadays. It's much more contemporary to hear about melanomas, skin cancer essentially. Plasma cells, lymphocyte cells, and leukocytes. So let's talk about esophageal cancer, or cancer of the esophagus. What is it? It's just, again, it's these abnormal growths or tumors in the esophagus. It begins, as all cancers do, with a malfunction of a gene that controls cell growth and division, and these cells growths are known as tumors. Although some esophageal cells can be benign, most are cancerous or malignant, and these two terms are synonymous. And they develop from the epithelium, and we just, if we go back real quick, we can see epithelium or the epithelial tissue, it's called, carcinomas, and they are the most common. The most common that we're going to see in this particular lesson, in terms of cancer, are the carcinomas and adenocarcinomas. So again, squamous cell carcinomas and adenocarcinomas are other common esophageal cancers. Adenocarcinomas are now the most common type of esophageal cancer. So again, adenocarcinomas are now the most common type of esophageal cancer. Esophageal tumors grow because no serosal layer is available to limit the growth. The spread of tumors to nearby lymph nodes is common because esophageal mucosa are rich in lymph tissue. So once they get into there, then they're going to spread to surrounding areas. And remember, this is very important, that more than half of esophageal cancers metastasize. So what causes it and who is at risk? And of course, we approach every lesson by thinking about what is it, how is it caused, who's at risk, what are the presenting signs and symptoms, and how can we develop a plan essentially? How can we prevent it? And then, of course, kicking around a nursing diagnosis in a direction to devise a plan. So what causes it and who's at risk? Well, there's modifiable and non-modifiable risk factors. The modifiable risk factors, the primary risk factors are smoking and obesity for esophageal cancer. This is paramount that you remember this. Primary risk factors are smoking and obesity for esophageal cancers. Obesity poses a 16-fold increased risk of esophageal adenocarcinoma, and this is directly from the American Cancer Society website. Increased abdominal pressure due to reflux or Barrett's esophagus contributes to cellular changes in the esophagus, increasing chance for adenocarcinoma. Malnutrition, GERD, and excessive alcohol intake associated with esophageal cancer. This is good information. This is important information because as we're doing our history and physical and we're doing our interviews on our patients, we're going to be able to, ascertain possible modifiable risk factors. And of course, if they start presenting with signs and symptoms that we'll later see, we can try to put 2 and 2 together there. The non-modifiable risk factors for esophageal cancer it happens in men more than women, and 5% of all cancers strongly hereditary. So there is some minuscule hereditary link. Signs and symptoms. So when we're doing our assessment, we have to know what to look for in terms of esophageal cancer, or even to think about if it's headed in that direction. As a nurse, you'll have to identify the previously mentioned risk factors such as gender, history of tobacco or alcohol use, dietary habits, weight, and esophageal conditions such as GERD. In addition to these, look for these signs and symptoms. Persistent dysphagia. Remember that dysphagia is with a G is difficulty swallowing, right? Like think of macrophage, being produced to eat bacteria or other microbes that are unwanted in the body. So phagia, swallowing or eating. Okay, so persistent dysphagia, feeling of food sticking in throat, painful swallowing, persistent chest or abdominal pain, as we know that the esophagus runs the length down of our chest into the abdominal cavity, regurgitation, chronic cough, hoarseness, anorexia, weight loss often more than 20 pounds, nausea and vomiting, and of course from these you can begin to have halitosis and hiccups. So how is it diagnosed? We do barium swallows with fluoroscopy, first to eval dysphagia, and that's pretty, so let's say a patient presents to their primary medical doctor and they present with some of these signs and symptoms like persistent dysphagia, feeling of food sticking in throat, especially with eating meats. The first thing the doctor's probably going to want to think about is doing a barium swallow with fluoroscopy. But the most definitive diagnosis is by esophageal ultrasound with needle aspiration. Obviously, we have to do the aspiration, send it off to see if it's malignant or not, or benign. So again, malignant is cancerous, benign is not. And then we have things like esophagogastroduodenoscopy, EGDs. It's a little easier to say EGD. And this examines the cells and possibly disease staging. There's also positron emission tomography, or PET scans as it's most commonly called, and it evaluates the response to chemo on cancerous growth, just to measure its efficacy. So there's a number of different types of treatments. Whenever we think of cancers, we always think of debulking, chemo, and radiation. And in addition to that, there's nutrition therapy. Nutrition therapy is the purpose of it is to administer food and fluids to support the patient who is malnourished or at high risk for becoming malnourished. As we looked at the signs and symptoms earlier, we touched base on anorexia, difficulty swallowing. So obviously this would have a vast effect on food intake. So we start with nutrition therapy and swallowing therapy. So the feeling of having something stuck in your throat would kind of discourage you or make you think maybe you might be at risk for aspiration precautions. But we do nutrition therapy. We conduct a screening assessment to provide information about the patient's nutrition status. The dietitian will determine the patient's nutrition status, the caloric needs of the patient to meet daily requirements, and then be sure the patient is weighed daily before breakfast on the same scale each day. Obviously, we will do that. And we got to make sure that the esophagus is patent. Careful positioning is essential for a patient who's experiencing frequent reflux, who has tubes. We got to teach our patients to remain upright for several hours after meals and avoid lying completely flat. And this goes for any esophageal abnormality or things that affect the esophagus, like GERD. Obviously, we don't want to eat too late. Obviously, gastric acid will be required to break down food and make it usable. So, that backup of acid production, you don't want to be lying down and that make its way up, exacerbating the already compromised tissues. And then remind unlicensed assistive personnel and other healthcare team members to keep the head of the bed elevated to a 30-degree angle or more to prevent reflux. We might even order semi-soft foods, thickened liquids, because they're easier to swallow. Of course, recording I&O is paramount for these individuals. All right. Also, we want to collaborate with the speech-language pathologist to assist the patients with oral exercise to improve swallowing, and with occupational therapy. The other thing we think about is chemotherapy, always when we're talking about cancer. The use of chemotherapy in treatment of esophageal cancer has only been moderately effective. It can be given as primary treatment if the patient is not a candidate for surgery. Obviously, the most definitive way, or the best way, is to get rid of the tumors or malignant growth altogether by surgery. So you may start with chemotherapy if they're not a surgical candidate. Excuse me. In most cases, however, chemotherapy is given in combination with radiation therapy to provide the patient the best chance of cure. But we have to remember that radiation and chemo can affect good tissue as well as malignant tissue. So there's a slew of side effects that come along with that. Radiation therapy by itself is to manage esophageal cancer. Also is only moderately effective. Radiation alone can provide palliation of the symptoms by shrinking the tumor. And this is important because we want to shrink the tumor and kind of leave it in an exposed state. That way chemo is more effective and the other therapies are more effective. Other therapies that we're seeing here: targeted photodynamic esophageal dilation, endoscopic therapies. They're therapies used in combination with radiation and chemotherapy, usually. Well, prevention is the key, obviously. Prevention is massive. As is the case with most cancers, early detection enables more effective treatments and better prognosis. So what does this mean? It means that you have to be astute to the signs and symptoms and the way the patient presents in his complaints or her complaints. So if you're hearing that he's having dysphagia, difficulty swallowing, especially with meats, some mid-sternal chest pain, non-radiating, or maybe that's radiating up the throat, halitosis, other things of this nature, start thinking about maybe cancer, weight loss more than 20 pounds. Start thinking about esophageal cancers. Assessment is critical, and we got to encourage lifestyle changes such as smoking cessation, diet with less proteins, less red meats, and discourage high-fat intake. So let's kick around this case study on esophageal cancer. A 59-year-old male was admitted to the hospital with dysphagia. Again, that's difficulty swallowing. And aphasia with an S is difficulty speaking. So I just wanted to clear that up once again. Dysphagia, difficulty swallowing, stating that he has been having more difficulty swallowing food even when he has chewed it thoroughly and drinks plenty of water. A CT scan shows an area for a possible esophageal tumor. The patient undergoes a biopsy and is awaiting results. The patient asks, "What am I going to do if this is cancer? What is the appropriate nursing response?" Well, we can approach this as we always do in terms of breaking down a test question. What is the case scenario here? Well, the case scenario is that the patient has been having difficulty swallowing, and even when he has chewed his food thoroughly and drinks plenty of water, CT scan shows possible esophageal tumor or some sort of mass of some sort. And then the patient underwent a biopsy. The patient asks you, "What am I going to do if this is cancer?" So this is the appropriate nursing response is the root. It's asking us, what is the appropriate nursing response? So let's break this down. I would choose to get radiation is a matter of opinion. Obviously, that we'll put a minus sign next to that. You will have surgery to remove it. That's not definitive. We can't, not every patient is a candidate for surgery, so we can't say that without question. So we'll maybe put another minus sign next to that. The doctor will go over the options with you. We can put a plus sign with that because that's true. The doctor will go over the options with him, but maybe this might exacerbate his already built up anxiety about it possibly being cancerous. The D, so that's maybe, we'll put a plus sign next to that because that's a possibility. But D, you sound as if you are concerned about the biopsy results. First and foremost, lets the patient know that you're listening to him, and it doesn't lead him into any opinion either way. It just kind of leaves it open-ended for the patient to elaborate. So I'm leaning towards D. Let's see what the answer is. And the answer is D. Asking the patient about his concerns about his biopsy results addresses his feelings and provides an atmosphere where he's invited to continue expressing his concerns. So most of you probably got that one, right? Let's try another one. The patient's history includes smoking, so the same patient, his history includes smoking cigarettes, which is we already know as from earlier in this presentation that smoking is one of the main modifiable risk factors since he was 17 years old, and drinks 3 to 6 beers per day. He says that he feels fearful and anxious about the results of the biopsy. He asks how this could have happened to him and what the chances are that the tumor will be cancerous. So again, it's the same scenario from the previous question. He came in with these presenting signs and symptoms. CT showed some sort of mass, and it was sent off for a biopsy to see if it's malignant. He's scared about it being cancerous. So the root is asking us, he asks how this could have happened to him and what the chances are that the tumor will be cancerous. So here are our options. Give examples of an appropriate nursing response. What would be an appropriate nursing response to how this could have happened to him and the chances that the tumor will be cancerous? Well, we know that from earlier in the study that the masses in the esophageal area are typically malignant in some way, shape, or form. That doesn't mean definitively and without exception, so we don't want to lead them into either way to exacerbate that anxiety. So something more therapeutic, such as the most common signs and symptoms of esophageal cancer is difficult swallowing, which is progressive. Although esophageal tumors can be benign, they are usually malignant. The two primary risk factors for squamous esophageal tumors are tobacco use and heavy alcohol. So that we could say, if he's saying he's drinking 3 to 6 beers a day, that may have contributed. And then, of course, the cigarette smoking. That's how it could have happened. The most common signs and symptoms are the esophageal, are the difficulty swallowing or the dysphagia. However, we may give him again something open-ended for him to elaborate after we've educated him on how it could have happened. So let's move a little further south and talk about gastric and colorectal cancers. What is it? So gastric cancer is stomach cancers, and they're typically adenocarcinomas. So let's go back and look at what makes up adenocarcinomas. So remember that again, adenocarcinomas come from glandular tissue, as we learned, okay? So typically, we just found out that gastric cancers are typically adenocarcinomas, which means they come from glandular tissue, okay? So usually begins in the glands of the stomach mucosa. Colorectal cancers are, colorectal is a two-part word, refers to the colon and the rectum, which together form the large intestine, also known as the large bowel. And there's a good little picture of the large bowel right here. Cancers of the colon and or rectum is one of the most common malignancies in the U.S., and they typically are, high diagnosed cancers in industrialized nations. Cancerous tumors in the colon and or rectum, most are adenocarcinomas again. What causes it? So what causes gastric cancer? Cancer of the stomach. Inadequate gastric secretions with the patients that have atrophic or atrophic gastritis. It is a process of chronic inflammation of the stomach mucosa leading to loss of gastric glandular cells. So this changes the structure of the cells. It creates an alkaline environment, allowing bacteria, especially H. pylori, to multiply. So obviously H. pylori is a big one in terms of a precursor to cancerous cells in the stomach. This infection causes mucosa-associated lymphoid tissue. Gastric cancer spread through the gastric wall and into lymph nodes. Adjacent organs may also be affected. Colorectal cancer, on the other hand, are also adenocarcinomas. They're typically polyps, and if you've heard of polyps in the colon, these usually turn into malignant tumors. They form from increased proliferation of colonic mucosa, and they relocate by direct spreading or lymph. So who's at risk when it comes to gastric cancer? Males more than females, again. 70% of new cases diagnosed in developing countries. Again, it's a lot of it's due to our diet and inflammatory responses of the gastric lining and the colorectal lining. So obviously, countries, industrialized nations where fast food is prominent, where lots of preservatives in foods are prominent. Eastern Asia, Eastern Europe, and South America. Average age of diagnosis is 70 years old. So that's kind of important to remember. 70% of new cases are diagnosed in developing countries, and you're a lot older usually when you get diagnosed, so around 70. We want to think about infections of H. pylori when we're thinking about gastric cancer, and also pernicious anemia, polyps, gastritis. And then this is important. People who eat pickled, salted, or smoked foods. Also charbroiled foods. Colorectal cancer is usually older than 50 years old, so this is a little younger. And African Americans typically are the ones most prominent to this. Younger than 40-year-old is becoming more prominent due to HPV, human papilloma virus. And then, of course, familial history of cancers always play a role. Not tons, but as we saw in esophageal cancer being 5%, this is about the same. Familial history always plays a role when it comes to cancer. Crohn's disease and ulcerative colitis. These are diseases of the stomach where or the intestine where part of the walls or different parts of the walls are inflamed or diseased. Long-term smoking, obesity, and heavy alcohol consumption are now thought to contribute. So, there's carcinogens in these things that we're ingesting and are causing these cancers. So what are some signs and symptoms? So what are we going to be looking for? We're going to be looking for gastric cancer, we're going to be looking for early signs. And some of these are indigestion, abdominal discomfort relieved with antacids, feeling of fullness, epigastric or back pain. And then, of course, in the advanced stages, we're going to see nausea, vomiting, iron deficiency, anemia, obstructive signs and symptoms, maybe, decreased bowel sounds, differentiations differences in bowel patterns, palpable masses, of course, weight loss and fatigue, and swollen lymph nodes. For colorectal cancer, we're going to look for rectal bleeding, anemia as a result, changes in stool consistency, occult or gross blood in stool, obstructions again, just like a gastric cancer, gas pains or cramping, indistension or palpable masses. Now, how do we diagnose these things? It's pretty much whenever we talk about diagnosis, we think of biopsies, of course. First thing, we always think of biopsies because that can tell us if we're able to extract pieces of those tissues, we can send them off to the labs to be evaluated to see if they're malignant or benign. Well, for gastric cancer specifically, we do a fecal occult blood test because, as we just saw in our last slide, gastric cancers there can be anemia. In colorectal cancers, there could be changes in stool consistency or occult or gross blood in stool. So again, we got fecal occult blood test. And that's an easy point of care test that the physician can do at the bedside, and they just use some reagent on a little card and take a little sample of stool and just wipe it right there and just drop a couple drops of reagent on it just to see if it reacts. Some other things are hypoalbuminemia, which would come up on a blood test, altered liver test or panels, elevated carcinoembryonic antigen or CEAs, EGD with biopsy, endoscopic ultrasound, CTs, PET scans, and MRIs, of course. MRIs, PET scans, and CT scans are better for soft tissues. Colorectal cancer is low H&H, of course, because of the blood loss. Fecal occult blood test, FOBT. Elevated liver enzymes, elevated carcinoembryonic antigen. And, of course, a contrast barium enema, double contrast barium enema. CT and MRI. Look up the double contrast barium enema and the CEAs, as these are not super familiar or super common tests to perform. So how do we treat these things? Of course, we always want to go straight to the source, and if we can incise it and remove it, that's the most effective way. So surgery, and then of course on top of surgery or in concert with surgery, or if the patient is a surgical candidate, we'd like to do chemotherapy, radiation. Most common side effect of radiation is skin integrity, breakdown, fatigue, and anorexia. Nausea, vomiting occur 1 week after therapy. And then of course a total or partial gastrectomy. Okay, and we know ectomy means removal of. Okay. Colorectal, on the other hand, is surgical resection, primary method, and there will be a snapshot of that where you take a portion of you remove part of the colon, and you do a resection. So we'll take a look at these pictures in just a second. Radiation therapy, chemotherapy, of course, colon resection, colectomy, and colostomy. Excuse me real quick, let me find that picture for you. Okay, so here's kind of a picture of what they do, where they have to do a resection of the colon here. And even this is really for the esophageal, when they remove part of the esophagus, but it's similar in the sense that they take part of the colon, remove the diseased portion, and then restretch it and reattach it. Okay. Okay, so let's talk about some case studies for the gastric cancer and colorectal cancer. At the oncologist's office, the patient tells the nurse that he has been experiencing vomiting and diarrhea. He states that he is tired all of the time and lost about 15 pounds over the past month. What is the priority diagnostic test that the nurse anticipates? So again, what's the case scenario? He's at the oncologist's office. He's having these symptoms, vomiting, diarrhea, weight loss, tired. And now the root. What is the root asking you? It's asking you, what is the priority diagnostic test that the nurse anticipates? So we have A, an EGD, B, colonoscopy, C, serum electrolytes, or D, stool for fecal or occult blood. Now, obviously, I'm leaning towards something non-invasive first. Let's see what the answer is here. The answer is D, stool for fecal occult blood, and let's see the rationale here. The most common sign of colorectal cancer are rectal bleeding and anemia. So as we're breaking this apart, we see that he's tired all the time, lost about 15 pounds. The weight loss could be from vomiting and diarrhea. But of course, for both colorectal and gastric cancers, fecal occult blood testing is indicated. Not only indicated, it's one of the first things you're going to do because it's so non-invasive. So if you chose that one, you were right there. Serum electrolytes would always be indicated. However, and especially with the tired all the time, we're thinking low H&H. He doesn't have that oxygen carrying capacity from the hemoglobin hematocrit. However, it's a little more invasive when we can just do a rectal exam and get that fecal occult blood test done at the bedside there. Let's look at another one. The patient is a 57-year-old male with a family history. So if we remember already, when we start thinking about colorectal cancer, 57 is typically when they get diagnosed, I mean, in their 50s, right? Now, 70-year-old was for the gastric cancers. So keep that in mind as we're breaking this apart. The patient is 57 male with a family history. I don't know how much familial history plays a role, but we kicked around numbers like 5%, so it does play a role. I don't know to what degree. So he has a familial history of colorectal cancer, not him himself, but his family, sister and father. He's 57. His diet includes lots of red meat and fried foods. He was diagnosed with ulcerative colitis 3 years ago, and treated for prostate cancer 2 years ago. So that's the case scenario. What is the root asking us? What risk factors suggest a diagnosis of colorectal cancer for this patient? So this might be a choose all that apply, and we have to think about this. He's 50 or older. He's male. He has a familial history of colorectal cancer. His diet includes lots of red meat and fried foods, and he was diagnosed with ulcerative colitis 3 years ago. Treated for prostate cancer 2 years ago. So let's see what the answer is here. So the familial history is part of it. Dietary habits, the red meat and fried foods. History of ulcerative colitis and prostate cancer. So those right there are the precursors. And that concludes my lesson. I just want you guys to make sure that you're looking over these lessons, and when you do so, I want you guys to keep in mind how we use this information. So we want to make sure that we're able to speak simply and explain what it is simply in its simplest form, how it's caused, at least no superficial level, how it's caused, who gets it, how it's treated, how it's diagnosed, and how to prevent it, and of course kick around some nursing diagnoses, okay?